All right, we'll go ahead and get started. A couple more people sit down. So I'd like to thank everybody for joining us for the David Kahler Visiting Professor Lecture in Trauma. Start by saying a few things about Dave Kahler. He was an important part of my starting practice, was very generous with his time and with his experience. Thank Vicki for joining us, his wife. We talked at dinner last night about the cost and expense of experience sometimes when you have to gain all of it firsthand. So I'm certainly appreciative of Dave sharing that and saving me some of that pain. But could tell stories about him all morning, what he meant or means to me, both personally and then within orthopedic trauma. But that's probably appropriate for some other more social setting. I'd like to introduce our trauma visiting professor, Dr. Florian Gebhard. He has more accolades than I could reasonably list, but foremost of those, he's the director of the orthopedics department at the University of Ulm and is our immediate past president of AO, having served from 2021 to 2023. He is a talented surgeon, researcher, educator, and I think one of the common ties that he has with Dave Kahler is that he's really been at the forefront of introducing technology into the operating room to improve techniques and outcomes. So thanks in large part to Dave, I was able to spend some time in Ulm a little over a decade ago. So that's a little bit of a tough pill to swallow. Time goes by quickly. And see their futuristic OR firsthand. We're going to learn about that some this morning. So it goes without saying, I feel a huge sense of gratitude for that experience and know that we're very lucky to have Dr. Gebhard here with us today. Appreciate him making the trip from Germany. Wasn't excessively complicated, wasn't perfectly smooth, but still great of you to do that and spend time with us visiting, seeing Charlottesville and the lectures today. Dr. Gebhard was always the first choice that Dave Kahler would bring up as somebody who we just have to talk him into coming to UVA. He, I think, had a lot of admiration for him. And I couldn't agree more that he's a perfect fit for the Dave Kahler visiting professor. I know he'd be proud to have you here. We're excited to hear your lectures. I'd like to invite you to the podium, Dr. Florian Gebhard.
Well, good morning. Thanks, Space, for the kind words. Vicky, good morning. Good to see you again, and good morning, everybody. And I'm really honored and feel privileged to be here because it was one of my bucket lists someday visiting this university, and I really enjoyed the day yesterday. So, for today, I've got two talks to you. One is about, so my department has two major research areas. One is basic trauma research. That's the first one. I assume it's a little more the dry one. Then we go to computer-assisted technology. That's a little bit more entertaining. And this will be the second talk. So, as that, the orthopedic trauma department is a little bit comparable to the size you have here in UVA. We are a level 1 trauma center and recoveries. We have a catchment area of 1.5 million people. So we have two major highways. That's excellent for trauma. So we are a very busy unit. And okay. 1, 2. Better? Still not green.
Flashing red and green.
No, it's green. Better? Ah, okay, so but I don't repeat what I just said. So okay, first part is about polytrauma management. And this one does not work now. So I press it here. And first thing is just, who is this male gray person here? Old as well. So I'm Munich born and raised. Yesterday I was asked about my famous soccer club. It's Bayern Munich, of course. And so this is a very traditional old city. That's a Royal Gymnasium I visited, and that's the Munich University. We have two in Munich. One is the LMU, that's the older one, and that's this one I attended. Then my training started with the army, and I had a, well, not so bad time spending my time. And you have seen even those days, it's quite a long time ago, we had a female part that supported us in the hospital. Then I had got some deployments. One of the most interesting one was a UN mission in Somalia. You can see that here. And I got the cover face of a UN book. So that was my first career step. I love that. And this is the town I'm working now. That's the highest church tower of the world still. On the bottom line, the green, that's the Danube River, which is one of the largest river of Europe. And then what I like most, you can see the mountains in the distance. It looks like very close. In real, it's an hour drive. But living there and working there is quite a lot of fun. That's about the size of the department. On top, you can see that's the old building. And now this is what Sis mentioned. That's the new surgery, which has been opened in 2012. And this construction is really fits to trauma care. So inside, it's a very functional system. On the right side, you can see this high-end OR room, which I will talk in my second talk about. These are my hobbies. My wife does not agree with everything, but it's fine. So what is the rationale to do polytrauma research? Okay, so there are statistics, and you can see that road traffic injuries, they really get up the ladder. So it's top 5 now globally. And today, because of the global development of conflicts, even a new type of trauma is increasing in numbers. And if you calculate this globally, that's a huge clinical and socioeconomic challenge, because it's always the young ones that get injured. And so these are the ones who are supposed to work and contribute to economics. And so it makes sense to take care for those who are injured in this age type. And so you will see now a few busy slides, but just give you the impression what is happening if you look for trauma research. So on the right side, you can see any trauma triggers a danger response in the body. And this is a systemic disease. It's not a local femur fracture or a forearm fracture. It's a systemic reaction that starts in any kind of trauma, simple fracture to multiple injuries. And then within the body, you have 2 lines. One is inflammation, protecting the body, and at the same time, regeneration starts. And it's always the balance between both processes, whether you have a good outcome or a bad outcome. And this starts at the very beginning. And you can see here on the left side, a lot of systems of the body trigger this inflammatory response. And the most important one, which we could demonstrate, is thoracic trauma, and the combination with total brain injury and soft tissue injury. And this is the one who are the most important things that happen. And then you can see here, there are a lot of signaling starting at the beginning, and at the first 24 hours, it's the hemorrhagic shock that threatens the body, and it's triggered by the coagulopathy, and all these pathways are the most important ones in the first 24 hours. And then it's very important that within the first 24 hours, the body gets the balance between pro and anti-inflammation processes. Otherwise, the process of tissue repair will not start adequately and will have a not so good outcome in the patient. And what we are doing since now more than 20 years, that we have a look at the total body as a responder to any trauma. So it's the whole organism that's in danger. And we are looking about the processes that are triggered by trauma with the end point, what's the outcome quality of life at the end of the day. And the response is in different levels. So you have fluid cells, organisms, and the whole body. And within that, there are different pathomechanisms that are started at the beginning. And the only thing what we can do in the first 24 hours, because we cannot redo the trauma, we can try to help the body to get stabilized between pro and anti-inflammatory response. And so what we are doing, we have a research group, which is like 60 people working on that one in different groups. And they look at all these different aspects of trauma. Because if you're getting a little bit older, then comorbidities like osteoporosis, diabetes, or Parkinson's disease, all these neurological disease, they are called disturbance factors, because if you get injured and you have some comorbidities, they will trigger totally different response to trauma compared to a young person that has no comorbidities. And if you take this into account, you see that's a very complex topic. And like 25 or 30 years ago, when I started to do this research, there was every second month a paper called The Magic Bullet in Trauma. And everybody proposed a new parameter. That's the one you need to trigger, like TNF-alpha was one of the first ones. They even did an antidote to TNF-alpha. And then, well, what happened? Many patients died more than the prediction was because they blocked the antibody. And this is and then science learned that it's always a pro and a con. And if you block the pro, then con gets too much. And some of the pro-inflammatory parameters also are helpful on the long run. So it's a big pot of soup. And if you take a spoon out of that, all the ingredients are in that one. And you can't decide which is the most important one in this type of soup. And so that's the challenge. And maybe, so that the other buzzword today is AI. Maybe AI can help in the future to sort out all these parameters which are currently on the market, as to say. But if you do research on that one, you can't do this on patients. And so at the beginning, we set up a model system for trauma. And this trauma is, the model is the mouse, because mice, you are available as a knockout mice, something deficit mice, and it's a very nice tool to mimic some sort of injuries or comorbidities. And then we created a mouse ICU, so we can take these injured animals on an ICU. You can see that they get a nerve monitoring using microelectrodes. We get venous lines in the mice or arterial line. We inflate them so we can breathe them for 24 hours. And we have imaging. You can see that we have a MRI. Meanwhile, we have a PET MRI where we can do a lot of imaging in these injured animals. And after that, we go into the bench and take histology and make cytokine profiling, all these things. And by that one, we can mimic what you can see on the lower end, a real ICU, but with a defined trauma and a repeatable trauma. And this comes very close to the real world. And so if you do this for a long time, there are a lot of fun facts behind that. You don't have to know about these parameters. So these are mediators of the brain. But what you can see here, or the readout is, if you drink some alcohol, you protect your brain. So doesn't make sense to drive drunk now, but obviously ethanol has some protective effects on the brain. So people, and we checked this in patients who had a little elevated ethanol level, they behaved different. And we tested this in our animals and they did the same. So that's nobody would have expected. We are working on that. So currently this group works, what's the best amount to drink before you get injured? But I can't give you the result of that one. Yeah. The other one is that if you are stressed at the moment when you have the injury, your body behaves different.
How can you test that? What we do an early maternal separation. So the new born mice are separate from the mother, and this puts them under stress. And then you can create a non-stressed and a stressed mouse, and they behave totally different. And the stressed mouse has an impaired bone healing, for example. You can do it the same setting as a psychological testing. If you have an old male mouse and put in a young male mouse in the same box, then the young gets stressed very quickly. And if you do this for 24 hours, you have an adult mouse that's also totally stressed. And if you then take them to the experiment, they show that they have a different inflammatory response and an impaired bone healing. For clinics, what is the readout of that one? Depending on the situation, you get injured, your body will react differently. Saying you're driving totally relaxed and something happens, then you are not stressed. But if you are like someone who is in action, like a policeman or a fire brigade officer, and if they get injured, they behave different because they are stressed, because they are in action. And at the long run, we don't know out of these findings whether this is a significant impairment of the bone healing, but there is an impairment which should be considered when treating these patients on the long run. And then the other thing is, so if you have a multiple injury, and I told you chest trauma is a very important one, you would assume that this patient has issues with healing. But interesting enough, another fun fact, if you got a chest injury, your wound will heal quicker. So the reason is not known, but there's a significant increased wound healing capability of the experiment where they got a chest injury. If you have survived the injury, the quality of regeneration, that's bone healing and regeneration of damaged tissue, is also an issue. And for that one, we use zebrafishes. So this is one species. If you cut the back part, it will regenerate within a few days. Yeah. And by doing that, and these are little filaments you can see on the upper left. And if you cut them, then you can see what type of cell reaction is needed to make a regeneration of the bone skeleton of these fishes. And this is an interesting part of our research. And these fishes get mediators, which we get out of our experiments from the mice. And then we can see whether the regeneration is changed in these species. This is work ongoing, but what we can see currently that we can mimic the bone healing in a zebrafish and can see what the zebrafish has different mediators during regeneration, what we are lacking. So, well, on the long run, maybe we find something, you inject, and then you regenerate the lost or amputated extremity. But I think that takes more than 10 years. Okay, so based on these laboratory experimental findings, we have a very straightforward setting how to treat multiple injured patient. I mentioned this, so these are the killing factors. And then we have some deadly combinations. If you have a chest injury and a pelvic injury, usually you have hemorrhage in this combination, or you have a TBI and abdominal, which is also hemorrhage injury. That's the worst you can get, because then you get an inflammatory response that really endangers the whole body. And so based on that one, we really believe in the second hit theory. And one of our parameters is IL-6. We discussed it yesterday on the hike. This is one of the parameters we rely on because it's very unspecific. You can't read out that if you have a high IL-6, that's exactly happening in the body. But you can say if IL-6 is increasing, rising up, there is something wrong, and you have to take care about it. If it is falling down, then there is a clear recovery. And IL-6 is one of the very, very early pro-inflammatory mediators. So it makes sense to look at that one. And so in Germany, we have a lot of air-based rescue systems. So usually the time from the site of accident to our emergency room is less than 1 hour. And then we give us 1 hour for the workaround in the emergency room before the patient goes into the OR or into the ICU unit. And so this is also to say at the site of the accident, and I will show you some data where we took the first blood probe at the site of the accident, because in Germany, there's always a MD on the helicopter. So, and if you just convince them that's worthwhile to do that, they will get blood probes at the site of accident. And all these parameters are immediately out. And usually, so the average time between something happens during daytime and the first responder is on the site is like 12 to 15 minutes in our area. So that means that within 10 minutes or 50 minutes latest, all these parameters are regulated. So the whole set of inflammation is already there at the site of the accident. And then you can see here these very early data where we started this research. A, that's the site of the accident. H is hospital, and you can see all parameters are already elevated, not very high, but they are elevated, so are in place. But then you can see that, so the time between site of accident and hospital, I told you it's roughly between 30 and 45 minutes. You can see an exceeding level of IL-6. And then the top level of IL-6 is the ones who have the severest injury. So that's the ISS more than 32 patients. And there's a clear correlation between survivors and non-survivors. So if you take the IL-6 as an early parameter, and this patient has a high rise in the IL-6, and he does not drop down the following day, then there is a strong likelihood that he will not survive. Whereas all the other patients, you can see they will drop down between day 2 and day 6 latest. And that's the window, okay? As soon as you can see that IL-6 drops down, this patient will recover, and you can use this window for doing surgery. We have a very strict system, typically German, which is given by our trauma society, and they define what you need in an emergency room. And a little bit different to your system, the trauma surgeon is the leader. So if we are on call, we go to the emergency room and see any kind of trauma firsthand together with the anesthetist. And it's a big struggle between us and anesthesia, who is the leader. But so far, we are the leader. But sometimes anesthesia claims that they are better than us. But as long as you do the research, you have a lot of information that the anesthetist does not have. And then you can challenge him with a few parameters, and he will say, okay, I'll go on. And then on the left side, that's the basic team that's always available if emergency comes in. And then we have the extended team, which have a notification time of half an hour to be in the emergency room. And then there's a clear setting. Sorry, it's in German, but to translate this takes too much time. But you can see in the center is the patient, and then everybody has a fixed position where he should do his work. And this will be trained. So even if you got the full emergency team with all these specialities, everybody has a clear area where he can do. And the aim of this setting is, first of all, education. Second, to make it as quick as possible that all these procedures are done in a time frame. And I told you the time frame is 1 hour. And this is written down in a textbook. It's available in English as well, and it's updated on a regular basis. And this is the recommendation of our trauma society, how to take care in the emergency room. Yeah. And these are then all these algorithms we follow, and you can see there's always a timeline on the left side to 10 minutes. That's what has to be done in the first 10 minutes. And we always start a clock that runs on the wall and gives us the time. And this has the colors. So there's a red zone, yellow zone, and a green zone. And everybody of the team can check, are we in time or are we late? Everything is on the register, and then you get your feedback. That's your hospital. That's the other ones that do better. And so that's a system where we can challenge each other. And it makes sense. So we have a really good workaround for the emergency room, and it's working together. And if you train that, it's helpful for the patient. And then, so we are all ATLS trained, so there's no difference in Germany. That's how we do that. And so the key issues are that we would like to have a fast scan within 5 minutes. Usually it's done by the surgeon. The radiologist comes in later. Chest X-ray is still written down within the first 15 minutes, but meanwhile, everybody gets a whole body scan. And so we just leave the chest X-ray, except the anesthetist wants to see where the tube is, about the if he has some troubles with inflating the patient. Otherwise, this we can skip. And then we do these very quick total body scans. And I think that was really a step forward, because within a few minutes you get everything what the patient has got injured. And then maybe most of you have heard about Christoph Peipi. He was in Pittsburgh for several years, then he went back, now he's in Zurich, but originally he's a German, and he made this stable, borderline unstable classification of patients, which I think is really valid globally. And if you follow these lines, then you can sort your patients in these degrees of stability and decide whether you go to the OR or you do damage control with an early total care, or you do the damage control. You just say, okay, no, this patient has to go first to the ICU. But all this clinical recommendation is based on the research data I showed you at the beginning. So this is not just experience, but it's really proven by animal experiments. And so this is what our policy, we follow this recommendation. So we do at day one, if the patient is okay, as much as possible, and we do all the things which are needed immediately. But then we give us a limit together with the anesthetist, say, okay, this patient can have surgery for 4 hours or 6 hours, but then he will cool out or he has to go to the ICU. Then we stop that, and then we wait. Then we monitor this IL-6, what happens, does it turn around and decline? And then we go for a second time of surgery, usually at day 4 or day 5. I know that's two sides, okay? That's a transatlantic discussion since many, many years about early total care and damage control, orthopedics. I think the truth is something in between. And if you take the individual patient and decide for the patient, then you will do a very good thing for the patient and will not harm him. So there will be patients you can do everything on the first day. But so we usually look for the agreement with the anesthetist and say, okay, you check blood clotting, the disorders and all these things during our surgery. And if you feel this patient goes wrong way, then we will shorten our surgical time. So the truth is somewhere in between, but it works quite nicely. And for example, this is a motor vehicle accident. Got the trauma scan, he had a spine injury, had a lung injury. And lung injury, as I told you, we believe that's really one of the game changers. If there's a lung injury, be careful, because that triggers a lot of inflammation. That's not very good for the patient. And then he was this type of pelvic surgery, which is not that spectacular as I've seen yesterday night, just a very simple fracture, and we don't treat that immediately. He gets an external fixator for the femur. Then day 5, he gets the final stabilization. And this is the type what we do nowadays with these minimally displaced fractures, that's computer-assisted screwing. And this will be part of my second talk. And 6 months down the line, this is more or less okay. And so based on what we find in the mice setting, in our mice ICU and trauma setting, we are totally believer of the second hit theory. And you have to know that this information is invisible. It's just, you can read your basic data and say, okay, I know that a mouse reacts like that one. This patient will do almost the same. So be careful, look at these key injury, like brain injury, thoracic injury, severe hemorrhage, because these are the triggers for blood clotting disorders and all these increased inflammatory response. And then we treat based on this injury pattern. as an early total care or damage control orthopedics. And this implicates that you do an early identification of these patients at risk, as I mentioned. If you have got this combination, then we are super careful in doing not too much, which is not really needed at the first day. And by that one, we always tell our people, you are not a bone fixer, but you're the one who stabilizes the patient and helps to resuscitate the whole organism to get the best recovery out of an injury. And so this is our philosophy. And we have on an average 300 of these ISS, more than 16 patients per year. So we have a sound experience in doing that. So thank you very much. This was the dry polytrauma story. Any questions to that? It's dry, I know.
When you are, you have a separate team in the ICU that is managing the patients.
Yeah.
The trauma surgeons aren't the ones you're handling it from the ER, but you're not actually handling ICU.
No.
We talked about IL-6. Is there a sort of a objective discussion, or is it a combination of subjective and objective when you're talking about the patients stabilizing for the next part of the surgery? The IL-6 trending down, but maybe they're still on a lot of pressor agents, or you know, maybe they have an ICP monitor that's kind of a little bit unstable. Is it do you have clear criteria, or is there a lot of discussion and talk and say, well, maybe not today, maybe tomorrow because of this?
Yeah. So it's a combination of both. So we have clear criteria. We want to see that all these scores go down or improve. IL-6 should go down. But if the patient behaves totally different, what the lab findings are, then we have to discuss this with our anesthesia or intensive care partners. And the big point is always neurosurgery, because they tell you, well, the brain will swell if you do that tomorrow. And I can't see a brain swelling and I can't predict that. So this is the most challenging part, to get the clearance in a total brain injury that you can do surgery. But usually, so our ICU people are interested to get the patient as quick as possible out of the area. So they are interested that we do this surgery as early as possible. So sometimes they push us to do surgery and we say, no, wait a day or something like that. So it's a fair discussion, and it's both. It's the patient, the individual, and our lab findings.
And is your discussion also, well, we're going to do percutaneous surgery, so we can, you'll have a discussion about the length of surgery, the time. And I noticed you plated that femur fracture that you were showing.
Yeah.
Normally that might get a nail, but was that a lung injury thing? Was that did you make an issue for medullary fixation on someone who had a bad lung injury?
So the one who did that decided that an MRI procedure, this was the MRI blade, is as good as the.
But it wasn't a lung injury.
No. So I know this is the other discussion, a separate talk about nailing and lung injury, but usually this patient is good within 24 hours for nailing, or 48 hours. That's not an issue. Well, less reaming maybe than a smaller nail, but that would work. Yeah. Okay.
Sounds like the down arrow might work now to advance that. You want to try to use the.
I did use that.
Let me down.
Maybe I should open the box here. Let me see that. The others. Got it. Good. Lessons learned. The other button. Okay, now more interesting part. So this is what I like most in my daily practice, doing a computer-assisted surgery. And so it developed is like 30 years. So in the mid-90s, this type of surgery was introduced first time for spine. One of the big names is Lutz Nolte from Bern. He introduced this navigation tool to spinal surgery. But in the 90s, the ORs looked like that one in our setting, and the hospital was on the lower left. This was the old 100-year-old surgical department. And this new technology did not really fit into our OR rooms, as you can see here. But we were lucky in 2012 to open a new building. And then the first time we were able to integrate this technology beforehand. And that really fits quite nicely. And so this is a little bit of a journey about how these technology developed. And this was in the end of the 90s. This was the system we got. It was called Medivision system. It was a Swiss engineering product, so very solid, and you could do almost everything with that. And they had strange things like a digital touchpad and a special tool to touch on this one. But it looked not bad. The camera was huge. You can see that if you take that in your OR room, there's little space left where you can do any type of surgery. So at the beginning, this was a lot of stuff we had to just take somewhere in the OR room. And on the right side, you can see every single instrument has a cable, as a power supply. And handle cables in a surgical field, being sterile, was really not the way to do that. But anyway, we were convinced that's a good technology, and we stayed with that technology. Then we had some strange things like gravity. I don't know until today why we had to use gravity. It should be around the globe the same, but you had to have this gravity tool. Otherwise, maybe there's some bending in the camera side or whatsoever. So it was really high-end technology. What we used, we were able to track our C-arms at that time. It was the ISOC, one of the first ones, and that you get the coverage. There were LEDs in it. And so the navigation system could track that. And at that time, that's the lower right. On the left side, that was my boss at that time, and he said, "You do that." So it was always the same. He was looking at the camera or at the computer and said, "Okay, what are you doing here?" And I was the other side, just doing something. And then after half an hour, he said, "Well, stop that. I do it now in a standard procedure." So this happened very often at the beginning, but by time it got better. At that time, you had a preoperative CT scan, and then the challenge was how to match the data set with your patient intraoperatively. Yeah, and one of the things in spine surgery, what we learned very quickly, your primary CT scan of the spine is done in a supine position, but then in the OR, you flip the patient in the prone position, and that will change the configuration of the spine. So it was a huge challenge to get this reference, which are the green and red dots, because if the surface you digitize is not the same, like in your preoperative planning, the computer will tell you, well, there's something wrong. What we started with first in spine cases, so thoracic spine was always very good. But then during surgery, you got this feedback, okay, matching error too high, that's what I just mentioned. Surface matching doesn't work. That was the end of the procedure, because if you don't solve this problem, and this was the time where my boss said, okay, sorry, I'm doing it now in a standard manner, where we had to stop that. But sometimes it worked quite nicely. So we did this at that time, open type of spine surgery, but used this computer systems to get a perfect position of the pedicle screws. You have to upload all this data set. So it's a preoperative data set of the CT scan, and the CT scanner got better and better, meaning more slices, more slices, more slices. So it was a challenge for the system. Can you upload all the slices? No, you can't. So there was always a limit. You had to talk to the radiologist. Please don't do not so much slices. I'm happy with a very standard basic CT scan. My computer can't eat that. But what we then did was perfect. So we had a perfect position of the pedicle screws. So the accuracy of the system was always good, or to say perfect. And this was the major argument in continuing with that system. So in 2000, we started to transfer this pelvic application into this spine application into the pelvis, starting with SI screw placements. And from the beginning, it worked quite nicely, except the matching. Again, there's a huge issue. In the spine, you have a very nice anatomical different surface. Each vertebra is a little bit slightly different, and then you can discriminate where you are. If you go to the iliac crest and take a few points, that could be in the beginning, in the middle, or somewhere else. So matching was a huge challenge, and you always have to have both iliac wings. And you can see here, we inserted even little screws before surgery. before we did the CT scan just to have a fixed point where we can do the matching. Not really the way you would like to do that. But then if you have succeeded that, the next step is always the OR. Then you get this warning. Then you have to go, there's something to be sorted in the wires. I'm not an engineer. I could not do that. So it was always the end of the surgery. Yeah. But the promising is we will start in 10 seconds. Okay. Then I start communication with the camera and fatal error in the camera system. Okay. So this is how we learned to do computer assisted surgery at the beginning. I can tell you, you must be very patient in these things. That's exactly the time point where the AO started to introduce a expert group just focusing on this new technology, because the AO said, okay, we would like to see whether this is worthwhile to follow up. Is this the future of trauma surgery or not? And from the beginning, you can see him here, David Kahler and the young Gebhard. We were partners in this expert group, and we spent many, many years just in following up this technology from a clinical standpoint, and that we were always in opposition to the engineers. So we made the clinical demands, and David was one of them who really said, I want to have this one. And the engineer said, oh my God, you really want that? In the lab, it works so nicely. But we told him, no, it does not work nicely in the OR. And you can see we're in different locations in the globe. That's typical for the AO. We even got to Australia because we thought we have to tell them there's new technology available down under. And so this group, and here you can see the group gets older and older, more gray. And unfortunately, since in December, we had the last meeting of the group. It's now finished because of new ideas. So coming back to navigation, then we go into trauma. So we said, okay, putting screws in the femoral neck makes sense. Then we started to do that, but you can see what you need and technical equipment in the lower left to do only these 3 screws. If they are in, they look beautiful. But the effort to do that is so much that you do it once or twice for a paper, but then you don't do it anymore. So then when we were more confident in the system, we went up to the cervical spine. You can see that's the clear benefit if you have these small pedicles with small screws to do a fixation, that you're really lucky if you do navigation. But again, you can see that in the lower right, all these cable, these reflectors was not a good thing to do that. And then the new generation of the C-arm came up, which were adapted to our needs. And this was a huge step forward. And but the issue was always at the beginning, if you do these scans, it's a huge of radiation. So at the beginning, we did a study very early where we used this TLD. This is a little crystals that just capture all the radiation, and you can put it on the patient. We put it on the C-arm and under the patient, above the patient. And if you heat them, they will tell you what you did on radiation on this patient. And the result was convincing that if you do, this was a spine procedure, the left side, you can see that's the average dose you're using to do a spinal procedure using a C-arm. If you do it CT-based, that's the next one. It's the lowest one because you rely on a preoperative data set. But as I told you, CT intraoperative turnaround the patient is the challenge. But the C-arm navigation and the ISOC, the 3D navigation, which on the right side clearly reduced the intraoperative radiation exposure to a minimum. And this was one of the strong arguments to continue with this technology, because we as the surgeons are the one who get the radiation every day. The patient doesn't matter. He gets it once, hopefully once in his lifetime. So he will take that. But for us and the whole OR personnel, I think this was one of the convincing arguments. And as time goes by, these platforms getting better and better. This is the SIGO, it's called. You have one here. This was the first system where we said, okay, we want to have this in trauma. When we asked Siemens to get this for trauma, they said, well, what's trauma? We don't know what is trauma. They are strong in cardiac surgery, neurosurgery, but we told them it will work. And so this is where all this started. And this you can see what's the advantage if you have a new hospital building, because to get this technology in an OR, that's challenging. Yeah, it's space-wise and all these wirings, because everything is connected, is a challenge. And you have a control room and you have a generator room to produce the energy and all these things. But building a new hospital, it's easy to integrate that. And what I did, because I'm still and was fascinated from this technology, these 3 ORs are linked. So we have one navigation system for 3 of them. So there's one computer system that just distributes the signal to the ORs. And so we have 3 OR suites in a row where we can do computer-assisted surgery now. We have the high-end one and 2 with a lower performance. And so it looks like at the beginning, and then you get all the stuff into it. And what the system is that this robotic C-arm and the OR table, they are linked. So that means the C-arm knows at any time of the day where the OR table is and vice versa. Because this is a closed system, you can identify any structure that you X-ray in a in an XYZ axis. Yeah. And by that one, you can register the patient while scanning the patient and then just transfer the data into the navigation system. And so this is just a few data. So in 10 years, we had 3,860 patients in this room treated. So it's really used during the weekday, every day. And you can see who's in lead trauma. So we are the ones who use it most, but we share this OR with vascular surgery and cardiac surgery and sometimes neurosurgery use it as well. And then it makes sense to make an investment for a system like that one. In trauma, we have done more than 2,000 procedures. And you can see spine is leading, of course, because this is what we do much more often. But in the second place is now pelvic surgery. Yeah. Then we do some tumor and some. So we're always looking at what can we do. So miscellaneous is just colibris. But whatever we thought we can do, we could do. So and this is just last year. So it hasn't changed much. So it's still spine is in the lead, followed by pelvis and some oncology stuff. And then we used the pandemic because then we shut down part of the hospital, but trauma was always online. But I said, okay, we can survive with 3 months not having the SIGO, and then we got the new system, which is now called Pheno. Siemens tell you it's phenomenal. So it's a nice system, but it's stronger performance, it's quicker, and it's a better imaging. And the beauty for me is always I can control the system. I don't need anyone else. So you see the touchpad on the right side, that's sterile covering. And whoever does surgery controls that. So you don't need any other person to do that. And you can see the new system is rather quick. So this is a scan of a pelvic. The size of the image is that you have a whole pelvis, both sides, both acetabular, both proximal femur. And it's a huge image quality. We spend a lot of time in draping scenarios. So we do a lot of dry testing. Now we are very to a level that it works quite nicely. Because if you don't do all these, consider all these things, you run into troubles when this swings around the patient very quickly. You can't stop that. There's a emergency stop in it. If it touches the OR table, then it will stop. But anything else, it will just move away, including your reference, which is very important for doing surgery. And then we have a lot of displays just all around the walls that everybody who's involved in the case can see, has a direct line to a monitor. And then everything is ceiling mounted, that we do not have any of these cables on the floor anymore. And so this is a very good standard setting. A few examples, oncology. So this was one of our first cases. This was a very rare G1 sarcoma of the oscillum posterior part. And so the challenge was to get this as an R0 resection and then without destroying the whole pelvis. And then we did a preoperative planning. said, okay, we get 2 screws into the posterior pelvic ring to stabilize the patient, and then we would use the same data set to do a guided resection. And what you can see here, that we did the screw, inserted the screw, and then we had guided chisels, and we just carved out the tumor by image guidance. And so the limit was 1 centimeter to the tumor to get an R0 resection. It takes some time, but it's very nice because you have always a full control where you are at the moment and where is your tumor. So we could do that. That's the final result. You see, we removed all the posterior part. It was R0. The pathologists were very happy, but the pelvic was still stable using these 2 screws. And so we now follow up this patient now in more than 10 years. He doesn't have any recovery of this tumor. He has a full recovery of the tumor. Then if you have a combination of bone and soft tissue, you can use your preoperative MRI data and fuse it with a preoperative CT scan. This is a metastasis in the spine area. Green is the tumor. And then we preoperatively fuse these images, and then we go to the OR. And what we then can do, we do an image-guided positioning of the pedicle screws. And then again, we use guided instruments to resect the tumor to achieve an R0 situation after that. And this is also very helpful because, as you know, the borders of a tumor are not really clearly seen if you do surgery. But if you get this information out of the preoperative MRI, then you can get enough distance to the tumor while doing the surgery. Same for a chordoma tumor in the pelvic. Preoperative fusing of both images. Intraoperative, you have a slider. You can switch between the full MRI and the full CT view. So whenever what you are interested in, just the bone for the screws or the tumor for resection, you just slide in that. And it's a very straightforward process. Pelvic, so these are just examples where you would like to say, well, that's a beautiful screw. If I can do that very quickly, that helps the patient. But sometimes it's very narrow. And so that's exactly the point where you can do computer-guided surgery. That's a case where I do not need computer-guided surgery, but I would do it at the Pheno suite, because if you do in this type standard surgery using this pelvic plate, then you can use the same system for the intraoperative implant positioning control and reduction control. Because you can see that's the MPRs, what you can do intraoperatively. That's a clear view of the whole acetabulum. And so intraoperatively, you're just clear, say, okay, that's a good reduction. The implant position is perfect. And we do not do any CT scans after surgery. Because if something goes wrong in here, as we have let's say one of the screws is not that perfect, then we would change it immediately, doing a second scan. And so by that one, we reduced the revision rate of cases to 0, which if you do that postoperative scanning. If it's a minimally displaced fracture like this one, then you can do a lot of screw splaining, and you can see the visibility or the representation of the bone is perfect. And then you do all these screw planings. At the end of surgery, you do an MPR, which is not super sophisticated. Your radiology does it, but you can learn it in 10 minutes. Then you have this final control, and you say, okay, screw position is good, reduction is good, the case is done, no further control needed. Yeah. Then by time you get more confident in the system, this was a 12-year-old boy who was overrun by a truck. He had this comminuted sacral fracture, and we said, okay, well, 12 years, open surgery may be not the best thing. And then what we decided that we planned just a long screw crossing both sides of the posterior iliac wing and the sacrum to stabilize this fracture. This is the screw intraoperatively, which we reconstructed then. And so we had only 2 step incisions. And you can see that at that time, this was the longest screw available on the market, was able to stabilize the posterior pelvic ring. And there was an uneventful recovery of that one. Meanwhile, we get longer screws. Synthes is producing longer ones. Then spine surgery, just a highlight. This is a 90-year-old female in a nursing home. And you can see that TH2-3 fracture there. And because of the deformity of the spine, it's the vertical fracture line. And this is a highly unstable situation. But as you can see, in this couch view, it's a huge osteoporotic spine. And if you do this in a standard open procedure, you may get into troubles. So we used our computer system, and you can see now the image quality is not good because it's a severe osteoporotic bone, but it's still good enough to decide whether your pedicle screws are in the correct place. And interestingly, on the right side, you can see that's the AP post-op X-ray, okay? It's a horizontal spine, and so both the 4 screws are just above each other. But it's a proof of the accuracy of the system because they're exactly at the correct place. And this is done by a step incision, so it does not harm to the patient. After a few days, she went back to the nursing home. Yeah, you can see that's the AP and lateral. So that's the lateral postoperative. With that image, doing surgery intraoperatively, I think you are really lost. And I think that's the beauty of the computer system, that this bridges the part between image quality and the need of the patient. Okay, what are we doing today? In 2 weeks' time, hopefully, we will introduce the robotic arm. It's in the delivery process. Why should you add a robotic arm? So currently, if you look at your cases, the challenge, especially in the pelvic area, is if you have an oblique surface and you try to get a K-wire or drill, you very often slip along the surface. And you can't hold the drill sleeve, the guided drill sleeve, as tight as you wish to do that, not to slip off. But this robotic arm does exactly, holds tight and doesn't do anything else. And this robotic C-arm, we will use it for pelvic surgery. It's just a guided drill sleeve holder, but you can roughly adjust the robot, and then the robot will automatically go into the perfect trajectory of the screw you're going to introduce this one, and then he will hold still as long as you want. You can do whatever you want. It's very strong. You have, if you move that, the whole OR table will move. So it's strong fixation, and then you can do your procedure just using this the trajectory given by the robot. I think that's it's not a huge step, but it closes the gap of 10% of the cases where you get into troubles by getting the accuracy when slipping off. And so, and it's totally integrated in the system. And I think that this part of robots for our profession, for orthopedic trauma, makes totally sense because it eliminates weaknesses in holding some aiming devices. I told you at the beginning, so when we studied these things, we did this type of radiation thing. So it's clearly it's less radiation. When we do the scan, everybody goes out of the OR room. Also, even anesthetists leave the OR room, so we do not get any radiation when we use the system. But if you're inside the OR room, then you have to be aware that that's the heat map of the system, okay? And you can see that that's not a standard C-arm, it's an angiography system, which produces a lot more radiation. And you can see that it's not really advisable or wise to stay close to the patient when you're scanning the patient. Needless to say, the darker the color, the more radiation you get. And so radiation is an issue, but it's not if the setting is okay and nothing is perfect. You can see here, sometimes you need some additional fixation devices like that one. Otherwise, it does not work. So you can get all your fantasy in this development. There's a bright open field for new ideas or even research, but it's a lot of fun and helps the patient. Thank you very much. Anything about this?
On your robotic arm, if you're holding the navigator drill guide, the 10% of the time there's an error. Is that because the guide will show a straight trajectory, but the drill will bend or slip, but the guide still looks like it's shooting straight down your trajectory, and so the drill will wander.
Yeah.
And you'll get a error screw.
It's a combination of left and right hand. So usually you have the left hand have the drill sleeve, and the right hand goes in with the drill. Then you push down the drill sleeve like at the surface of the pelvic, and then you feel it does not fit there. Then you try to press it. When you press it, you slightly angulate it automatically to get a better fixation. And then if you insert the drill, then you bend back, and then you have a combination of a slight tilt in your drill sleeve and a double tilt because you press the drill in the opposite direction. And at the end, this always means that you have a deviation of the entry point and a deviation of your axis. Usually it's okay. It's not super dangerous for the patient because you always have a wide safe zone, but sometimes it's really annoying if you don't succeed exactly the one you planned. Yeah.
Does the computer mark that when you take your scan at the end? Where you said you put your screw and then where it actually ends up, or is it something you just see, I intended it to be here, but it's actually slightly off?
Not automatically. What you can do that you upload your final scan again in the navigation system. Then you can fuse the planning data set with the result data set, and then you can see the difference. But and it's the end of surgery, so it's additional purpose. Okay, that's it. Thank you very much for listening.
Thank you very much. Thank you.
Okay. Get a wrong address then.
Yeah, there you go.